Good evening, all. Thank you all for coming in short notice. We really appreciate your presence here today. Hope you will enjoy the stay, this presentation and discussion. So, a quick introduction. My name is Dr. Dagmai. I'm a representative of Aster Hospital, and I'm also staff in St. Paul's. And Professor Dr. Somshakar is one of the eminent surgeons in India, and he's also expertise in HIPEC and PIPAC treatment. He has many fellowships in different surgical oncology, gynae oncology, robotic surgery, and peritoneal surface diseases. So I'm sure you can share experiences well, and we hope that it will be a fruitful event. Maybe he has many profiles, so I'll just give him time to introduce himself, and maybe you can introduce yourself step by step.
Thank you very much. Lovely to be here. Nice to meet all of you. I was interacting with some of our colleagues, oncologists, hepatobiliary surgeon, colorectal surgeon, and I know a lot of gynae onco are also there. So a warm wishes from India and from my hospital, Aster International Institute Onco. You know, no other field so much of advancement happen as it happens in oncology. Actually, we make fun in our oncology circle that if you just take a week vacation, go out with your family for a break and come back, lot of recommendation, guideline has changed already. Like for example, you know, in last 9 months, some 12 guideline in prostate cancer has changed. 22 new drugs have come. Similarly, now this ASCO, if any of you have been following that, I was there, I had 2 research publication in ASCO, Chicago. Almost 11 new practice changing guidelines have come. Now, you know, in colorectal cancer, if you just check MSI and MMR, you don't need surgery, you don't need radiation, you don't need anything, you can just cure them with immunotherapy. Similarly, in breast cancer, stage 4 breast cancer routinely live 10 years if they are eligible for CDK inhibitors. So that's the fun we say. Oncology is changing so rapidly. In no other field, the translation research which happens on the bench is applicable to human beings so fast. So to cover everything in one small session is very tough, but I will try to put how I adapted this technology over last 2 to 3 decades to make our patients better. Because you know, the training of surgical onco in India is very long. We almost spent 5.5 years to do med school, then 1.5 year to do our training program. 3 years of general surgery is compulsory, otherwise you can't enter specialist surgical training. Then 3 years of surgical oncology training. Then I was in UK for a long time, where I did my FRCS from Edinburgh. I have a license to practice all over Europe, Australia, Asia, and over 23 countries. Then I was in US, where I did my gynec fellowship in Mayo Clinic in the gynae onco. Then I was in UPMC Pittsburgh, where I did my breast surgery fellowship. Then quite some time I was in Paris for hepatobiliary pancreatic. All of you must have heard Bismuth, and I was honored that I was in his unit, Bismuth's unit, with Rennie Adam. So I had a very good time. Then I was in Taiwan and Korea for thoracic onco. Then I did my robotic training. I was one of the first guy who started robotic in India almost 13 to 14 years back. And I hold the record of doing largest number of robotic cancer surgeries, close to 4,000 surgeries. Nobody has done that much. And I am a mentor globally, so I travel to France, Asia, China, Japan, US to train people in robotic surgery. And we run a lot of fellowships under me. So we have a university breast oncology training fellowship. So many of my students I've trained. We trained them in the breast oncoplasty, sentinel lymph node, breast conservative surgery. And the training under me is recognized in UK. So they get trained under me without any qualifying exam. They can straight go to UK. A lot of my girl students have done that. Then we have a training in HIPEC, hyperthermic intraperitoneal chemo, for advanced ovarian, colorectal, all these cancers. So currently I am training a lot of gynae-onco from Bangladesh. They come for fellowship under me for 3 months. Then we have minimal access cancer surgery fellowship, which is 1 year. Then I have international robotic surgery fellowship. 130 students from US, UK I have trained. So it's a very big academic center. I'm extremely busy. I do about 190 major cancer surgeries a month. Almost practically every day, no Sunday holiday. If I'm not traveling, I operate. The only time my vacation is when I travel, like this is the lightest day for me. Otherwise, we do a very high volume, and in India. So I'm going to share a little bit of what technology I picked up traveling world. And India is not a very rich country. We are also financially and resource challenged. Yet how we can adapt it in the given setup. That is what we do. You all are aware now, India has launched its robot called Indian Robot, Mantra SSI, very cheap. It is 1/10 the cost of an American robot, and the cost of surgery to patient is same as laparoscopy. So a lot of things are affordable in India now, best and yet affordable. So I bring warm regards from Aster Group. We have more than 300 hospitals in world, not many people know that. 300 hospitals, and in India we have more than 25, and our main thrust is oncology. Aster International Institute of Onco, globally everywhere we have this cancer center. So I am a global chairman for the entire Aster DM Health Group Medical Advisory, and I am a global director for all the 300 hospitals. So in Bangalore we have 3 very big cancer hospitals. If any of you want to visit, you are most welcome. Based on your area of expertise, you can spend some time. We have a lot of surgeons who spent now last 2 weeks. They wanted to see GI cancer, esophageal cancers, gastric, then colorectal, they spend, and gynae-onco, come breast. So anybody want to just come around, I'll help you. We have 3 big cancer hospitals. We have a lot of fellowship training program, and we have a structured MDT program. So I'm happy to take you. The whole concept of treatment in oncology now has moved from maximum tolerable. When I was getting trained in UK, we used to say cancer is a deadly disease. Death certificate with date not written. Patients are scared of us. People think the oncologist, the surgeon, the medical oncologist, radiation, doctors, and their treatment is more dangerous than the disease. So they run away. That's why they come late. Second, they have a fear of organ loss. You have a voice box cancer, they think they will remove. You have a rectal cancer, they'll think they'll make a permanent stoma. You have a breast cancer, they will afraid breast will be fully removed. You have a kidney cancer, kidney will be removed. But you now know that what happened 3 decades and today is not same. Today, this is an era of minimum effective treatment. We understood. Now after I started doing robotic surgery over last 12-13 years, less than 1% of the patient I remove and do nephrectomy for renal cancer. 95% of our surgery is robotic, nephron sparing partial nephrectomy. The incidence of permanent stoma has come down from 36% to under 7% with robot. And you know that I do about 600 breast cancer surgeries every year. 96.5% is the breast conservation rate in my hospital. You do a core biopsy, you look at the ER/PR HER2 neoadjuvant treatment, breast conservation. Initially, whole life I have removed all the lymph nodes, but we don't do that. Now we do sentinel lymph node. Laryngectomy, I hardly remember doing. Now this is an era of multimodality, organ preservation treatment, where is minimum effective treatment and not maximum tolerable. But still we don't compromise on the cosmesis, quality of life and oncology. Now the whole concept is this. When I was getting trained in oncology and I was in UK, Lancet published this line. Every doctor, surgeon, oncologist should know this. Ideal line. If we do anything above that, we do harm to patient without benefit. If we do anything below that line, we are dangerously too conservative. So understanding that ideal line in each surgery of the cancer is very important. I'll give an example. Doing mastectomy is above the line. No benefit. Now it is proved by all the trial breast conservative surgery is superior in survival than mastectomy. Women who undergo mastectomy for breast cancer live less and inferior than breast preserving. It is proved now, published, phenomenal trials. So removing the lymph nodes of armpit and axilla or a groin, suppose a lady has a vulval cancer, there is a penile cancer, going and removing all the lymph nodes even when they are N0 and giving a lymphedema is well above that line. So now we do sentinel lymph node. So what is dangerously below? Not doing adequate surgery with negative margin, sentinel lymph node, good quality surgery. So for every surgery there is an ideal line. That's why when I returned back to India from all my trainings in US, UK, then France and Taiwan, I decided that I will put all the cancer care under one roof to my patients. Because we know in cancer care, one person, me, myself doesn't do, it's a joint team. Treatment is just one part. Counseling, psychology, pain management, nutrition, rehabilitation, and all the concepts are very important. All of us should sit together. If you happen to come to Bangalore, my cancer hospital, all this unit I have put it under one roof. All available under one roof. And with one consultation, I put everything. Surgical onco, ortho onco, gynec, uro onco, HIPEC, robotics, medical onco, hematology, hemato-onco, very large number of stem cell and treatment for thalassemia, treatment for sickle cell anemia, nuclear medicine, therapy, oncogenetics, oncopathology, nuclear medicine, genomic analysis, pain, palliation, intervention, all together. So this is my trajectory. I came back to India somewhere around year 2001 and I decided what we don't have, I'll put everything for everybody. We started a very early bone marrow transplant program and I decided no patient will get treatment unless every patient is discussed in MDT tumor board together with my colleagues and we agree upon the treatment. And I started ambulatory chemo. I put a daycare, outpatient, local anesthesia chemo port and ambulatory Baxter pumps. So patient walk around in their work home and they take ambulatory chemo. We started the very early robotic program, liver directed TheraSphere program we started first, radio guided, image guided surgery we started. We purchased the first robot and I started the program. Then the HIPEC, that is the hyperthermic intraperitoneal chemo for a stage 4 peritoneal cancers non-curable. I got that first machine. I have done the largest HIPEC in entire Asia, which is 3000. And if you Google my name, Pesogi Peritoneal Group International, I am regarded as one of the top 10 leaders in the world in that field. And we introduced artificial intelligence in oncology decision making. So that is what we actually did. I cannot cover everything today. You will get bored and you will not be able to go to dinner. So I'll just show few of them, which is a very large number. And I have more than 300 publications. If you go to Google or PubMed, put my name, there are more than 300 publications, virgin research in my name that are published and presented across the globe. So several of them where I have a large number experience and I am considered as the leader and I have very high volume presentation I am going to share with you. Number one is disease more dangerous, treatment dangerous than treatment, cancer. We cut from here to here, patient lie down like this, 2 days ICU, pain, hernia, rehabilitation, not able to go to work for months together, financial toxicity. All this changed when open surgery moved to laparoscopy. I always say that in the human life, this is the place where Lucy is there. Presumed all the human beings, Homo sapiens, came from here. Evolution versus revolution. If you are a surgeon who believe, I'm not going to wait for Darwin, where one day chimpanzee is going to become human being and I'm going to become normal. No. We have to see the moon and decide, I'm not going to take my wife for a candlelight dinner happy and come home. We'll set our foot on that moon. And these revolutionist people are the one who changed the history of mankind. That is called the pyramid of excellency. To be one of the best, you have to do something more than other people, not just live and enjoy your life. We know that laparoscopy is very good for gynecology, general surgery, but for oncology very tough. Because in cancer surgery, oncological outcome, removing the adequate lymph node margin very important. So most of the cancer surgeons in the world were little not skeptical in adapting laparoscopy because it is user dependent, a lot of tremors are there, you can't do high quality surgery. But luckily, robot came way back in 2000. First it was used in a bypass surgery. Instead of cutting the sternum, you can just do 2 small keyholes, go there and do a coronary bypass. So in robot, there are 4 arms to us. Imagine you have 2 arms and you can do wonders, and if God gives 4 arms to you, and each arm is 3 millimeter tip, and you can have an endowrist where human beings hand cannot do. And such 4 arms are so good, you can peel the skin of the grape without touching the pulp of the grape, all by yourself without assistant help. In surgery, you know that sister help, assistant help, everything you can do alone yourself. That is the beauty of this robot. How does it help? In robot, you see everything 3 dimension. Everything is magnified 10 to 12 times. 4 arm is there. It has got a laser embedded in that. It has got an ultrasound at the tip of the robot. It is very stable. Surgeon just sits with a cup of coffee, you cannot. It is a known fact, a surgeon who stands 12 hours and operates, or a surgeon sits and operates. And intuitive movement, right side movement is right, no tremors. Suppose there is a senior surgeon, say that I become one day 60 and I develop tremors. I have a good brain experience, but tremors, robot cancels that. A person who has Parkinsonism can sit on a robot and operate with the tremors. And that is the surgery. This is a surgery. I am doing a right hepatectomy for a hepatocellular cancer. In India, very common. That is a vena cava. Liver is above the vena cava. That is a caudate lobe. Such small blood vessels opening into vena cava from caudate. Look how I can do with robot and suture it. All without a tremor, and remove that liver. 4 arms, laser, stapler, vessel sealer, stable platform. Such beautiful surgery I can do. You don't have to be a robotic surgeon. You can sit on a robot first day and you can beautifully with your left hand put a suture with 6-0 suture material as thin as our hairs. How does it help? That robotic platform is very stable. This is a surgery. I am doing a Whipple surgery for a pancreatic cancer. There is a portal vein. Tunnel is formed on the portal vein and with pancreatic tumor to separate. Look at the stability, vision and comfort. That is what the robot gives. This is a rectal cancer surgery, sphincter preserving surgery. How beautifully I can draw a suture like a flower vase. That is in between the 2 lobes of the prostate. On the levatrine pelvic diaphragm, I am putting a beautiful pursing suture on the anal canal to restore the continuity to avoid stoma. I have done about 1500 robotic rectal cancer surgery. Incidence of permanent stoma has come down to 6%, which used to be more than 25% for me. So that is the benefit you can have with this. Second, those who practice urological cancer, gynec cancer know that this urological cancer, prostate, urinary bladder, uterine cancer, endometrial cancer, ovarian, they all go to para-aortic lymph node. Because the lymph node always carries the lymphatic of the blood vessel. We know that on the right side, a testicular vein, ovarian vein, opens into vena cava below the right renal vein. On the left side, it opens into the left renal vein. So the lymphatic go. So with robot to do a high para-aortic lymph node, very easy. This is the first paper in the history where I mapped out how easy it is to do para-aortic node. You can read that paper. It is published in my name. With robot, how you can do. This is a Whipple surgery where 3 mm pancreatic duct I am anastomosing into the jejunum. Those of you who do pancreatic surgery know this is the toughest surgery step. But that is the most pleasurable stuff in the robot. The 3 mm duct is magnified 10 times. So how much it will look to me? 3 mm into 10. It looks like a 13 mm duct. A suture, easily I can suture. So beautiful surgeries you can do with this. This is a D2 radical gastrectomy. You know that in cancer surgery, not just removing organ, lymph nodes. Stomach has got multiple blood supply. Branch from the hepatic artery, then left gastric, right gastric, celiac trunk. So here I am starting from the hilum of the liver, following the hepatic artery. We call that station 10, 11, 12. Then I will go and walk on the hepatic artery to the gastroduodenal artery. Then I'll go to the celiac trunk. on the superior border of the pancreas, beautifully, bloodlessly with robot. In about 30-40 minutes, I can do a D2 radical lymph node dissection in gastric cancer, which is the most important. Look at how stable it is. That vein which is being seen is a splenic vein. In open surgery, you can't even touch that. If you touch that, you had it. But in case of robotics, see how stable I am holding. All the node packet I am holding. I am working now on the celiac trunk. Splenic artery, hepatic artery, left gastric. And how nicely stable I can go and do a bloodless lymph node dissection. That is the beauty of this particular robotics technology. All these patients go home in 3 days, painless, one shot of antibiotics, no drain, ERAS protocol. And it is a big boon in thorax. India has very high volume of esophageal cancer. You know, in India, people eat very spicy food. So much spicy that food pipe gets burnt off. Second, smoking. And then heavy coffee drinking. So food pipe cancer, esophageal, is very common in my place, where I come from, South India. Every week I do 2 esophagectomy. You know, the problem with esophagus is God has started it in neck, put it in chest between 2 lungs behind the heart, and he has also put it in the abdomen joining the stomach. It has got lymph nodes in the neck, it has got lymph node in the mediastinum, it has got lymph node in the celiac trunk. To do this surgery, 3 areas you have to go in and you have to reconstruct. How complex surgery it is. I always say in my surgical training, when somebody get trained, the last year I make them do this surgery. Then I say, okay, now you are fit, you are a bold man, you can go. I have done the largest robotic esophagectomy in India. I have published this, how to do it. I do it with patients lying down without single lung ventilation, with a very short learning curve. With the robot, what it takes to learn 100 cases in laparoscopy open, you can master in 10 days because of the technology. It is proved by many studies, open surgery, laparoscopy, robot, which is easy, robot is the easiest. This is a aorta division. I am doing a high paralytic lymph node dissection. Look at how easily I am doing. It appears as if you are doing a Picasso's beautiful Mona Lisa painting. One arm holding the node, aorta vena cava. Look at the way the robotic arm I am able to use it. Beautifully bloodless. That is the aortic fork division, left common iliac vein. In 30-35 minutes, you can visit a YouTube channel in my name, Dr. Somshekhar SP YouTube. 130 educative videos are there mine, which are used by Royal College of Surgeons, UK, Australia, Canada for teaching my videos. That is the inferior mesenteric artery. Look at the way bloodless you can remove the node. That is the duodenum and the right renal area. This is the beauty of this technology to do that. That is the right renal vein, that is the right gonadal vein opening into vena cava. So bloodlessly you can do this. Full video is available on my YouTube. You can watch. A lot of trials I published. People come to me across the world to learn how to do this. This is some of the surgeries which are easy. This was a young boy who had a tumor in the chest to the right of the trachea, at the inlet of the thorax and the neck, below the subclavian artery. You know how to remove this surgery? You have to cut the ribs, do a thoracotomy, remove it, keep him in ICU for 1 to 2 days on ventilator, ward 1 week, 3 months rest in the home, lifelong pain. The same patient, way back 2010-11, I put the robot, see the tumor there, that is the lung which is collapsed, that is azygous vein, that is the superior vena cava with the phrenic nerve on that, heart beating here. Look at how the robotic arm are just like a swan neck. I am separating the tumor from the pericardium. Bloodless, high magnification, forearm. One arm will retract the lung and pericardium, another 2 arms. I did this surgery on a Saturday morning. I admitted him. Saturday afternoon I did. Sunday this guy, young boy, went home, and by Wednesday he could go back to his work. That is the beauty of the surgery with the robot which you can do. There is a couple of other surgery you can do, like oral cancers, larynx cancer. Normally what happens is thyroid surgery and the oral cancer surgery. Thyroid cancer is more common in ladies, you know that. Typically we cut the neck, lifelong, this tumor is removed. In India, I did the first trans-axillary scarless thyroid. She was a very young fashion designer, 22-year-old girl, not married. She didn't want this scar. And then I could do her surgery through the armpit and axilla. Single day she went home. You know that when we do these oral surgeries through the mouth, 4 hands, 2 surgeon assistant cannot go, Caesar cautery cannot go. So what do? We cut the chin, we remove the tumor with 1 centimeter. They can't eat, we put these feeding tubes until they heal. We sometimes put this tracheostomy. This was the first surgery in India done, transoral robotic surgery. He was a very big politician and a minister. He told, if I have a cut on this, it's a professional suicide. He came down to me. I put the robot into his mouth. You can see that corner. That is me sitting. Nobody has abandoned. Don't think everybody abandoned the patient. This is me here. See this leg? This is how in the robot the mouth looks to me. No longer I feel I am in a mouth. I feel I am in a big playground. I use the robotic laser. I remove that cancer at the junction of the voice box, base tongue and the lateral pharynx with bloodless 1 centimeter negative margin all around. What is the goal in cancer? 1 centimeter tridimensional negative margin cures any solid tumors. You can see how stable, no assistant, nothing. And that is epiglottis and the larynx inlet on the back side. I could remove this margin with negative margin. Same day night patient home back. Tubes, no scar. Now this is a thyroid I did my first. You can watch it in the YouTube. Through the armpit hair bearing area I put the robot, go to the thyroid. That is a robotic harmonic. And the nerve below that is the recurrent nerve which controls the voice. How thin it is. If I touch that nerve, it stops functioning and voice change happens. If I injure that, they end up with a tracheostomy. So you can see how with one robot I am retracting the thyroid, another arm I am retracting the nerve, and with the robotic harmonic how beautifully I am taking. We know that in the thyroid 3 problem, voice change, calcium loss because of parathyroid gland injury, third is a scar. All 3 are sorted out here. You can see this is the parathyroid gland. In open surgery, you can't see only. Your boss says this is a parathyroid, you can't see, but you have to say yes. But in robotic, all the time it is seen. This is the tumor I removed, this is the girl without that. After that, I have done 190 patients. A lot of patients from Dubai, Oman, all these rich sheikhs, wives, daughters come, they don't want a scar, and we do very high volume daycare surgery. We discharge them without that. So this is something which is very, very. Second surgery is a rectal cancer surgery. What I normally do is I take this rectal cancer tumor, I put it in a bag, then I take a purse string, the whole cancer and the rectum is removed per rectal through the natural orifice. We call that node surgery. Like mouth natural orifice. Through the normal anal canal I go down, and that is the sphincter which controls puborectalis sling which controls. I preserve that sphincter. I bring down the anastomosis. Specimen is removed transanally without a cut on the abdomen. No, and then we restore the anastomosis with a circular stapler. Then we add a saline and do leak test and no stoma or a bag. And this is how the sexual nerves are preserved. You know, any pelvic surgery, prostate, urinary bladder, gynec and rectum, the sexual nerves are lost. The first penalty unfortunately a patient pays in prostate cancer, rectal cancer, urinary bladder, gynec and rectum is loss of erection, sexual function. But in robot these nerves are seen and preserved. So they have the best sexual function. Also the robot has a special green light laser. How many of you have seen the Superman movie? He can sit here through the wall, you can look what's happening. Like that in the robot, I can give an IV ICG. I don't know which node is involved. The moment with a click of a button in the robot, I change down to a green light infrared laser mode. Now that shows me where that lymph node is. Sentinel lymph node. That is available in the robot. If I see now, I don't know where is that node. The moment I click the button on my hand control of the robot, it will tell me in the gynec cancers Now in endometrial cancer, every surgery is sentinel lymph node. So I know now where that node is and where I can remove. Also there is an ultrasound in the robot. So we do a lot of these surgeries. We have done a lot of surgery for Ethiopian young girls. These pediatric children, they develop a lot of this bone tumor, sarcoma, kidney cancer. They are cured, but they come with lung lesions later. So I put the robot, I use the robotic ultrasound. In that lung, I see where that nodule is and I go and remove. Lot of patients we have done from Ethiopia. You can go to my YouTube and you can see children. 5-year-old, I have done a pancreatic tumor. 6-year-old, I have done a lung lesions. And hepatectomy, I have done hepatoblastoma for a 6.5-year-old child. Neuroblastoma, 5.5-year-old child we have done. So this really helps for us to go ahead and do. Robot also has a firefly technology which will tell me where the vascularity is done in the bowel. Like for example, now I don't know where should I join the intestine. For my eyes, I don't know where is blood supply. The same thing if I give IV ICG and I use this firefly mode, that robot will immediately tell me where the tissue is dead, where the tissue is alive, where there is a vascularity, where it is not, in 60 seconds. You can see that now I know where that green light and I can put the anastomosis there. This is a case where I am doing a robotic partial nephrectomy for kidney preserving. I don't know now this blood vessel I have to sacrifice or not. Because kidney has a lot of polar vessel if you are urologist. I can put a clamp, I give IV ICG, now I will see the remaining kidney is viable, perfusing or not. See that in spite of clamping it is alive. So I can sacrifice that vessel. When I do this liver lesion, it will show me where is the liver metastasis, where is the margin of normal liver versus this, and I can do that. All this is available in the robot. And the beauty is there are two machines connected to one. When you do driving school, you and your instructor both can control. Like that, two surgeons can together and operate on one patient. This is the beauty of this particular robot. So in robot, all this facility is available. Now this is a new robot which goes through the umbilicus, belly button, opens like a snake. You do all the surgery, prostatectomy, rectal cancer, colectomy, radical hysterectomy, lung, esophagus, come out. All they have is just that scar below the umbilicus, no incision, it's available. Now the new robots have come with a microscope, so you know where your cutting tumor is there, free or not. This is one field which I have done large amount of work in the world, more than 3,500 to 4,000. You can Google any based on your area specialty, you can watch. Because I am a surgical oncologist, I do high volume of uro cancers, GI, thoracic, upper abdomen, and gynec-onco. A lot of surgery, hepatobiliary. Whichever you are interested, you can watch. The second field was surgeon I cannot see. So there is a field called as, this developed in Germany. We call that field RGS, radio guided cancer surgeries. There is a nuclear medicine dye tagged which will guide you to do surgery, and this part of surgery is sentinel lymph node. Remember, in breast cancer, if you remove all the node, they will develop lymphedema, elephant hand, which is permanent debilitating. Now we have developed this special probe in India. It is available from Karl Storz, Germany. You know what is the cost? It is roughly about $1.2 million. Nobody can afford. We developed in Bangalore 1/10 the cost in Indian probe. We give this dye behind the nipple areola. We use this Indian ICG machine. It's available, CE marked. If anybody of you practice breast oncology, please come down to my center. I will train you in sentinel node. You can take that Indian machine to you, very easy. Once I inject, it will show me real time in front of my eyes where that node, it is traversing in front of your eye, and it will show where that node is there in the armpit, and it stops there. And you can go to the axilla and you can follow that, and you can see, remove that, it will be waiting for you like a spark, like a glowworm. Now whole sentinel node is done through that. I do almost 3, 4, 5. So I published this, how to do this. This is the Indian machine which I told you, 1/10 the cost. Plastic surgeon can use to see, is the flap viable. He can do lymphedema surgery. You can do cosmetic surgeries, you can do colorectal, gynae onco, breast surgeries, flap viability, everything, and this is available, you can go. Also, when there are women who are operated outside, they come with lymphedema because those surgeons don't have this. Then I do this particular surgery called lymphedema surgery. What we normally do is, we give to the hand and then identify the lymphatic, we do a LVA. We join the lymphatic channel during surgery to the vein so that you don't develop lymphedema. You have seen that when you do a penile cancer block dissection in the groin, or for vulval cancer or breast cancer, they develop lymphedema. So we use this lymphatic channel and we anastomose that during surgery to every patient of breast cancer so that they don't develop the lymphedema. This is called as a LVA surgery. We always do in our patients and then they don't develop. Also, when you do a cosmetic surgery, you can use this machine to see which part of the breast is viable. So when I do a breast reconstruction, there's a mastectomy, but see the cosmesis, edges heal well because viability is known. So this is the beauty of this machine which we normally use. The second surgery, suppose there is a hidden tumor in the breast, I can't feel. How do I remove it? Or there is a parathyroid tumor behind the thyroid, or there is a bone tumor inside the bone, or there is a small lung lesion inside the lung, small liver lesion, then this technique is called as ROLL. What we do is we give a system EV and we have this handheld gamma probe. We navigate it, it will tell where the lesion is. We go and remove that lesion and we can target it with a negative margin. This is called as ROLL, a radio guided occult lesion localization. I published a large series, you can read this. How we use it in parathyroid. If we give IV system EV, if you keep it in the neck, it will tell where that parathyroid gland is. Only go and remove it under local incision in a few millimeter and remove this tumor, patient goes home. I published in a NMJ journal, you can read this. Now the last few minutes part of my talk is, so far I showed the technology, how quality of life can be improved, you can make it minimum invasive, how early cancers can be bettered. Now I'll show you a technology where advanced non-curable stage 4 cancer you can cure. You know that gastric cancer, colon cancer, appendix, pseudomyxoma, mesothelioma, ovarian cancer, gynec, they all come with a peritoneal spread, ascites, extensive spread of cancer all over the abdomen, where most of them die in 9 months because of cancer, cachexia, intestinal obstruction, can't eat. That is where a new technology is available called as a HIPEC. You see a tumor like this, 99 out of 100 people think this is non-curable, right? Everywhere tumor, nothing is seen. This is a distinct specialty called as PSM, peritoneal surface malignancy. I am one of the leader in the field of PSM with top other colleagues across the world. The same patient, after me and my team, 9 hours of surgery, looks like this. Better than any of a new abdomen. Whole peritoneum is removed. Whole diaphragm stripped, all the surface of the intestine stripped, glycan capsule of liver removed, not a speck of cancer is seen. Now can you see this? Nothing is seen. Whole retroperitoneum is bare, aorta, vena cava, ureter. Can you see that liver? Right hepatic vein, middle hepatic vein, left hepatic vein. All the tumor, everything is clear. That is where we master these techniques called as peritoneal surface malignancy. See how various techniques are used to remove the nodules. That is when we do this HIPEC pump. You heard of a dialysis pump for kidney, liver dialysis. You have heard of various other technique. But there is a special dialysis for a cancer. So this is a US FDA approved. After we do this surgery, we put these thermocouples, 41.5 degree heat in 90 minutes. We pump all and kill the cancer cells. So this technique is called HIPEC. My work is published in multiple places in the world. Annals Oncology, NMJ, JCO, presented in US. What we think are totally non-curable cancers, we go ahead, remove all the peritoneum like a parachute technique. See this? I have not opened the abdomen, I am retroperitoneal. All the cancer is removed. After I call this frying of Chinese noodles. That is a HIPEC. We do hyperthermic intraperitoneal. How it changed? 2001, I have done more than 1300 surgeries. When I adapted it in my life, what was thought to be inoperable, no cure, 91% of the patient I could operate. Initially, where survival was 32 months, patients it crossed beyond 70 to 80 months. Then we added a new technology called as the German technology PIPAC. We know that if a chemo is put to the abdominal cavity, high dose, more penetration, less complication, better cure. If you add heat, cancer cell will die, hyperthermia. Chemo with hyperthermia, even better. Now if you add pressure to that, you convert the chemo vapors into nanoparticles, aerosols, spray it into the abdomen through a special device called as capnomet. This whole procedure is a daycare laparoscopy, 7 minutes. 7 minutes. You just spray this and discharge the patient with pressure. It's called PIPAC. What is thought to be a patient who may not live 6 months, routinely are alive for 3-5 years with an excellent quality of life. All these my papers are published. You can go back and read. Also, there is a new technique called as a optical coherence stoma. During surgery, when you remove any lump, you don't have to do frozen section. This machine will tell have you removed it completely with negative margin. Tool which are MagSeed. It has a magnet. So when you use this magnet probe in the hand, it will tell where the tumor is and you can remove them. It's all available now. And when we do breast conservation, we put this something called as Biosorb. I just put this particular thing inside during surgery like this, close it, and after 6 weeks it is absorbed and it leaves only a marker there where we can give a radiation. There is a big publication which I have done, you can see that. So because of this, I procured a machine. The first machine in entire Asia is ours, a robotic radiation during surgery. I do a breast removal. This machine goes into during the operation theatre. This is fitted into my OT. 60 seconds gives electron and you don't have to do radiation later. Imagine a breast cancer patient comes, I remove the lump, I do sentinel lymph node, and then I do an intraoperative radiation. And for rectal cancer, pancreatic cancer, this is the first machine we have taken. It's called as IOERT, available in my center, only place in entire Asia with me in Aster Cancer Hospital, where we offer this to all the rectal cancer, pancreatic, gastric, stomach, so they don't have to stay to take radiation for next 8 to 9 weeks, and we can do intraoperative radiation. So in conclusion, if you want to look with this technology, we moved from what we thought as a maximum tolerable treatment to minimum effective treatment, multimodality, organ preservation, and better cosmesis, better quality of life. So this is the motto we launched the Aster Hospital. It is not just any other comprehensive cancer center, but it is a complete cancer center where we are a group of 30 oncologists. We work together under one roof, all of us in one hospital. All of us, one big group. Every case is discussed in MDT room. Very huge center. If you come down, I will be happy to show. We have 2 to 3 robots. We have this capnopen, all the types of ICG special machine, multiple types of laser, nerve monitor unit, intraoperative radiation, frozen section in the operation theatre, and an advanced specimen mammogram digital. The tumor board is in my OPD. So we meet every day, we discuss everything, and then when we give chemo, we use this scalp cooling system, Paxman, so the child and the lady doesn't have a hair loss or alopecia. Because you know that most of the women are very sensitive and they are afraid to take chemo. So we have 4 such units we do every day, morning and evening. Every edition is in MDT, and the training program I do is accredited by UK, International National Cancer Grids. We have formed something called as Aster Cancer Grid, where all 21 cancer hospitals under my group is linked together for academic research training. And every patient sees not just me or my team, but they see the dietitian, oncophysiotherapy, psycho-oncologist and genetist. All the things are integrated under one value. So I'm not interested in putting just high number case, but I want a value-based cancer hospital which is integrated and supported by patient support group. So that's why I always call this logo when we made, it is a bud, positivity of hope, blooming, using modern technology, high class, world class treatment, yet affordable with humane touch and compassion. Thank you very much.
Thank you very much, sir. So we will open the floor for discussion, questions, and we will wrap up after the discussion and we will have a dinner. Any questions, comments?
How many of you are surgeons in this, gynec onco, and any surgeons in this? I know I met two of you, both of you. Good, surgeons will enjoy this the most. But whenever I speak, my colleague physicians, medical oncologists, pathologists, they love this. They say that, it is like a snapshot of everything what a surgeon can do, because so it's very nice. So otherwise our surgical colleague really will understand in depth of it. But it's important for us to know what are technological avenue available. Gone are the days we say, okay, I cured your cancer, removed the tumor, but I left you with disability, quality of life, organ is lost, whole life suffering. No, this is not that era. We have to really think of patient quality of life, multimodality, organ preservation. And the advancement that is happening in medical oncology, genomics, immunotherapy, targeted therapy is phenomenal. Now we rarely use chemo for everybody. Most of them is genomic personalized medicine. And radiation is not like old time. Now we have moved to hyperfractionation, single shot intraoperative radiation, SBRT, volume breath controlled machine, gamma knife, fiber knife. So things have changed a lot actually. Because of that, stage 3, what we thought was a tough cancer has become curable. Stage 4, lot of cancers are curable. If you can't cure, they live 5 to 10 years with excellent life. That's what has happened in oncology field. Please.
Thank you. It was an excellent presentation. And I have 2 questions.
Please. You can introduce yourself, so I can. Thank you.
Thank you. I am Dr. Betel. I am gynae oncologist. I have 2 questions. So the first one is our surgical and gynecologic oncologic practice are at infancy. So what does Aster has to offer?
Yeah.
Is there any thing taught in skill transfer, short courses? Because we have many young fellows who are interested in this. And then the second question is, I don't think you can offer a travel for all patients to travel to other parts of the world for this. So what's the future plan? Do you have any plan to have a hospital in Ethiopia? That's the second thing I would like to know.
Sure. The first one, I am first an educationist, teacher, and then a surgeon, and people know that worldwide. So I have been awarded with Teachers of Teachers Award for training maximum number of oncologists across the globe. I always believe everything what I learned, if I just keep with me and I die, I didn't do anything, it just dies. If I teach 10 of my students, then they teach 10, 10, 10. My skill, my technique, my knowledge stays eternally and serve the humanity. I am very much for training. I am a part of a group called as AGOI, Association of Gynec Onco India. I am also a part of ESGO, European Society of Gynec Onco, and also part of IGCS. If you go to any of those bodies, I am a trainer. In fact, next week I am conducting a global international MDT for ovarian cancer for the European Society of Gynec Onco. You can Google, my link is there, I am coordinating. I do extensive skill course in India. We have case observation. Like currently I told, like what you are, the Bangladesh is in the same infancy. Just now gynecologist has recognized a separate field as gynec onco. Otherwise 99% of the gynec onco are done by general gynecology with help of surgeons. Now they have started, but they are never able to do this peritonectomies, HIPEC, advanced lymphadenectomy. So we have tied up with Bangladesh. I train every 3 months for young. Young means they are not freshers. They have completed their training. They are in the tune of like assistant professor, lecturer, junior consultant. They come to me and I am training. Right now there are 2 gynec onco young who have come. I train. So we do 2 months of training. whoever is interested, be in touch with doctor. I am more than happy to get you trained depending on what level you are. Like if you are a senior consultant like you, maybe a 1 month may be okay for you to learn. Second, we do cadaver course. In Bangalore, we have an advanced institute of training. I do a structured 4 to 5 days hands-on cadaver course. Like next month, I'm going to Singapore. The University of Singapore want to start a high-tech peritonectomy CRS course for ovary. I'm training 10 gynec-onco there. I was in California 2 months back to train them. And I was in Hamburg 4 months back to train. So we do these courses. You can look for that. You can come attend the course. We have all the lectures, talks, videos. Then we take you to cadaver lab. We make you do all the complicated surgeries. Then we certify you. However, if somebody is a student, we have 1 year training program. I know it doesn't suit people who are busy practicing, but so 1 year university training program we have. So whatever fits you, you can join. So we are more than happy to do it. That is one. Alternatively, if you have a local society, if you form, we are happy to come and do the training program here. If you identify a group of gynec-onco or a breast surgeon, what you want, we can come here for 3-4 days. We can do a structured training course for you in gynec-onco, and we can do training program we can do a live surgeries. We can make you do it and understand, and you can get trained. Then you can come back once, watch I am doing, and then couple of exchange you can do it. So this is what I do it regularly. We have trained a lot of people, both in breast, colorectal, minimal access, robotic, laparoscopic, and gynec-onco. I am happy to do that for you. Both there, both here. I can work the way you want. Second question, absolutely, I agree with you. No patient should travel out to other country because cancer treatment is family treatment. You want to be with your loved one. You're going through your tough time and the most loved one stay here and you're alone. It's very unfair. And less than 0.1% people can be treated by migration. It's unfair. That's not the way. So it should be we develop here. We are working with the Zambian government, where we have an exchange program. They come and they get trained with us for 2 months. Then I go there, we stay for 1 week and we do a camps for them, surgical training program for them. And then one of my team stays for a month and come back and they do it gradually. So we are more than happy to do that we have something called as Aster International Academy Institute. But the initiative should come from you people. Because without involving the local body, local association, it doesn't work. Then 1-2 people will learn, they keep it for themselves, it doesn't happen. So if you come through a society, like if you have a gynec-onco society, you have a breast society, you have a surgical onco society, we can train them how to do a sentinel lymph node. It doesn't take more than 3 days to train. How to do a good radical hysterectomy, I can train. How to do a good ovarian cancer, I can train. So I'm more than happy so that eventually 75% patient can get treatment here. There are some 25% who need to travel for those infrastructure. It doesn't make sense putting a big PET scan, big radiation machine. It doesn't make sense because they cater only 10% of the patients. So those patients only need to travel. Yes, please.
Thank you. With regard to host, I'm colorectal fellow.
Fantastic.
Thank you. Most of the time we practice open surgeries and our minimal invasive surgery is just as infancy. So maybe it might be difficult for us to transition from just open surgery to robotic surgery in a very few years. So our next step might be laparoscopic surgery.
Yes.
So what can you offer us? Because most of your videos we have seen is prior to the robotic surgery. What kind of training can you give us specifically that targets to laparoscopic?
Like in India, we have basic laparoscopic, advanced laparoscopic, and site-specific laparoscopic training. Somebody who is already a good laparoscopic surgeon but want to start a colorectal program or upper GI. So we have a program called as FALS, FALS. I'm one of mentor for that. Fellowship in advanced laparoscopic surgical training. Please look for this. We do it twice a year. It's a 5 to 6 day structured course. So we do FALS colorectal, we do FALS gastric, we do FALS hepatobiliary, we do FALS robotic, we do FALS hernia, we do like that. So you can attend these courses. It is a certified course. Beautiful degree certificate you get. So it makes sense to come and attend because we are a pool of 60 mentors like me who come to the course and train. Because there is no one person can train everybody has a different. So you can do these false courses, and then you can take a observership for a month in a center after the false course, and easily you can pick it up. So I would recommend you to do these courses, which we routinely do. Yes.
Okay, thank you. My name is Bakato. I'm asking you about this HIPEC surgery for
Yes.
peritoneal carcinomatosis. Do you do it for every type of cancer or selected group of cancer?
There are guidelines for that. Now for each cancer there is a guideline. I will take it one by one. Peritoneal cancers are classified into primary and secondary. Primary is a primary peritoneal carcinomatosis and mesothelioma. Secondary is gynec, colorectal, gastric and appendicular. For ovarian cancer, we do for every stage 3C and stage 4A. So now it is proved and level 1 evidence that all advanced ovarian cancer should have a HIPEC. You cannot have surgery alone. If you do good surgery and IV chemo, 90 out of 100 will recur within 1.5 years. It is known. So for ovarian cancer, all patients who receive chemo, we do HIPEC. Now somebody has got treated for ovarian cancer, they recur. If they are platinum sensitive, which means the recurrence happened after 6 months of last chemo, then we do HIPEC. If they recur within 6 months of the last chemo, called platinum, we don't do. So this is for ovary. Now for colorectal, we do a peritoneal MRI. I have a dedicated team which know how to interpret the peritoneal MRI. This is one case where PET scan is not important. A good peritoneal MRI should be done, and we put an index called as PCI, peritoneal cancer index. They will map out the cancer nodules in all the abdomen, and if the index is less than 15, the index can be 1 to 39. Less than 15, HIPEC will help, and we offer HIPEC. If the index of cancer is volume of above 15, HIPEC will not help, we do PIPEC. Now for gastric cancer, all those patients who has a peritoneal spread but no extra abdominal disease, means they don't have disease outside the abdomen, everything is only in the peritoneal cavity, we give 4 cycles of FLOT chemo. If they respond to that, and if the PCA index is less than 9, we do HIPEC. So for appendicular cancer, all low grade we do, because pseudomyxoma, that is the only option. So there is a guideline, it is published, but in a nutshell I told you. So any patient who has peritoneal cancer, we do an evaluation, what disease, what origin, recurrent or primary, what is the cancer free interval, peritoneal MRI, PCA cancer index. Based on that there is a guideline. So we do based on that. Actually you can visit my YouTube channel. You can write down my email. My email is somusp@yahoo.com. You can all write back somusp@yahoo.com, or you can just go to YouTube, type my name, Dr. Somashekar SP YouTube. Everything is there. Lot of videos, presentation, publication. You want to learn how to do a good modified radical mastectomy. Globally, my video is regarded as the #1 video with 10 million downloads. It is used in Netherlands, Royal College of Surgeons, American College, as a teaching video for a student who starts a breast cancer. You can read there, you can see that it is with a voiceover. So you can get more information, or you can write to me. My email and mobile is, doctor, you can just touch base with me. I am always accessible and available. Yes.
Hello.
Yes.
My name is Asteer. I'm a gynae oncologist from Black Lane. So my question is regarding your success in radical hysterectomy using this either laparoscopic or robotic surgery. Yeah, because after LAC trial, most of the European nations have turned back to doing the open surgery due to the lesser survival, and also after radical hysterectomy, we do lymph node dissection as well. So there was also a lesser lymph node count when we came back to this technology, using technology lymphadenectomy. So is the survival not compromised after we do these things? And also, can you tell us your experience regarding this laparoscopic or robotic surgery for advanced ovarian tumors? Because I believe we need open surgery in such a scenario.
Okay. The first question.
Okay.
You know that now there are 3 other randomized controlled trial after LAC called as ROC and RAC trial. I am a part of that. ROC trial is robotic radical hysterectomy for cervical cancer, and RAC trial. LAC trial is the only trial which showed that if you do surgery by laparoscopy compared to open, pelvic and vaginal recurrence are high, and the outcome is compromised. Now you know that in the field of gynec-onco, people don't accept LAC trial because it was conducted in a very inferior center, done in a country where they don't see CS cervix. You know where CS cervix is high? African, Asian countries. We do hundreds of radical hysterectomy. We see CS cervix every week. Do you know when I was in Mayo Clinic, during full 1 year, only 1 cervical cancer I saw. Mayo Clinic gynae-onco department, the largest gynec-onco. 1 year, 1 cervical cancer surgery. In the LAC trial, all the trial is done only in US and Europe. Nowhere. Those surgeons who are part of that laparoscopic surgery have done 11 radical hysterectomy in their entire life. And they do 1 surgery in 2 years. They are not even eligible to do open surgery. They did laparoscopy. That is not a surgery you would want to, right? Professor knows, if you are doing a hepatectomy, if you do 1 liver resection in 2 years and you are part of a laparoscopic liver resection, will you trust those trials? The people in the LAC trial do an average 1 surgery in 2 years. Most of them have not done open surgery themselves and they are a part of laparoscopy. Second, all the recurrences, 80% that happened in LAC trial happened in 2 institutions. There were 27 centers which were part of LAC trial. All the recurrences, 2/3, happened in 2 centers with 2 surgeons. If a technique is wrong, recurrence should have happened in all the 27 centers. 70 to 80% recurrence happening with only 2 centers with 2 surgeons says, is the technique wrong or is the surgeon wrong? Second, in LAC trial, they didn't use MRI. So somebody told, I have a 1B1 cervical cancer. You know 1B1 at that moment, 1 centimeter to 4 centimeter. So they never had a central review of the pathology, stromal thickness assessment, MRI. That is why people criticize LAC trial severely. But however, randomized control trial is randomized control trial. Only trial got published. So people told, you go back and audit your work. You see your open result, you see your lap and robot. If you are wrong, you stop doing it. If it is same, you don't do. So what happened? The Canadian Society of Gynec-Onco audited all the laparoscopy robotic CS cervix done versus open. They published it. It is published in the International Journal of Gynae-Onco. There is no difference in survival. Memorial Sloan Kettering Group, Professor Mario Leto, they analyzed their last 10-year robotic and laparoscopic CS cervix open. They have published in SGO, no change. The Sweden government initiated a Sweden Cancer Registry. 760 patients of CS cervix treated over 20 years. Open and laparoscopy, it is published, no difference. When this LAC trial came, I audited my result. Open surgery and robotic, I had no difference in the recurrence and outcome, so I didn't stop. Now, RAC and ROC trial are completing, and I've already spoken with my colleagues because we are a part of it. The result is no inferior. So, if you are a trained person, do it. If you are not trained, please do a good open surgery. No pressure to do laparoscopy or robot if you can't do it, right? If you know how to do a good open surgery, do that, patient will thank you. You are already a good surgeon. After many years, you are learnt, please do it. No problem. But wait for these 2 trials, it will prove that there is no change. So people will do that, that's no problem. Now for ovarian cancer, I recommend not to do minimal access in ovarian cancer, because if you rupture the ovary, it becomes 1C, chemo is required and recurrence is double. Having said that, some people after chemo, shrinking, are trying to do laparoscopy, but they are part of clinical trial in a very expert group. Don't do it unless you are expert. Do a good open surgery. I always say that for advanced ovarian cancer, single incision surgery. Incision from zephysternum to pubis. So you can cure them.
Thank you very much, Professor. I think it was a very nice presentation. So it was also interesting for me to see the thorax and the oral cavity because I am a gynecologist, right? So my book. So, I mean, my question is just out of curiosity, just the Da Vinci. Do you have any cost minimization in India?
Yeah.
Because in the places wherever you have mentioned, in the Memorial Sloan Kettering, I have a chance to meet Mario,
my great friend.
Yeah.
We both do courses together in India, abroad. He is my great friend.
Yeah. So the cost, any modification in the Indian context? Because the Da Vinci is interesting to see, and it has excellent outcomes in terms of the oncology.
But very expensive.
Yeah, it's expensive.
So what we have done is, I was also part of the development. If you go to your mobile and type SSI mantra, SSI space MANTRA mantra, I have joined hands with a very world-renowned robotic cardiac surgeon from US of Indian origin, and we have this advanced engineering technological institutions in India equivalent to MIT and Harvard in US. They are called as IIT. You must have heard it. They are supposed to be the best engineering training colleges in the world. Indian Institute of Technology, IIT. So with them we have developed this robot called SSI Mantra. This Indian robot has got 5 arms, much better than Da Vinci. The cost is 1/10 than Da Vinci. With one cost to purchase Da Vinci, you can purchase 6 Indian robot. With one Da Vinci, the surgical cost to the patient is roughly $4,000, but in ours it is $350. So now that is available. You can Google. In India it is being sold. I also have now taking a new SSI Mantra. So we changed the whole thing. Having said that, even in Da Vinci I have worked out a cost reduction module. What I do is, we have adapted ERAS. I do a daycare surgery for gynec and colorectal. I use single shot of antibiotic at induction. I don't use vessel sealer, harmonic and all. I use only monopolar, bipolar. I use 2 arms instead of 4 arms, and I do hand CN suturing rather than stapler. And we apply ERAS. We don't keep Ryle's tube, Foley's catheter, drains, and discharge the patient. So I could bring the cost of robotic 20% less. Remember, robotic is 50% more expensive than laparoscopy in high volume centers. If I can adopt this ERAS protocol, single shot of antibiotic, no drains, no IV fluid, same day meals, walking around, I brought 25%. So I'm 20-25% expensive than lab, it's fine. So that is where we have done, but we are now almost moving to Indian robot. You can Google it, it's called SSI Mantra. I was part of it, and it's available. Now in Dubai, the first SSI Mantra is being put. So Middle East has an access, and they have already come and met most of the governments in African continent. And in Africa there is a rule, if there is any device which is licensed to use in India and being used on human beings, you don't need separate license, it can be put automatically. So they foresee about more than 100 Indian robot will be put in African continent in coming 2 years. Thank you, it's a lovely meeting. I know everybody has to have a dinner. These are never ending, it looks exciting, but I'm always available. My email is there, you can take it. You can Google with my name, my email, my contacts all are available. I'm available on WhatsApp also. You can write down my WhatsApp number. It is 984571212. You need any help, advice, or if you're coming down to Bangalore, drop into my OR. You want to have a look of Surgeries Institute, I'm happy. If as an association you want, I am happy to come and train people how to do sentinel lymph node, breast conservation, oncoplasty. I can train in gynec onco. We can have a structured training program. Necessarily don't have to happen in India, it can happen partly here also.
Thank you very much all. So we will give a round of applause for his presentation. Thank you again. There will be a dinner at the ground floor, so please all join us for the dinner. Thank you very much.